Okay, so everybody's here. This is group 2. Should be about 10 of you, and so
Yes.
Yes.
so we have 17 here. So 17 means that there's 7 of you that are foreigners.
Yeah.
Okay, fine. So let's start with Kitab Al-Fatihah. Okay. So as what we have done before, there will be two case kind of like problem-based discussion uh, or problem-based learning that we're going to do, and obviously we've done it. I think a couple of weeks ago, last week or 2 weeks ago. Um, so basically, one of you will take charge leading the case. We will do this case like how you do in a long case. And then I will ask you for the question. Just make it like a viva type of case. Okay. So two of you will be presenting. So who's going to go first? Izati.
Yeah, me.
Okay, fine. All right, the floor is yours. The audience is yours. So obviously, the rule of thumb is do not say anyone. Always pick name. Okay.
Alright.
So if you say anyone is not going to help, not going to be helpful. But if you pick up names, the onus will be on the said name to respond to you. Okay, right. Go ahead.
Is it? Assalamualaikum warahmatullahi wabarakatuh. So today I'll be conducting the first case. So let me read about what the case is about. So Tom is a 10-year-old boy referred to outpatients by his GP with a 2-year history of recurrent headache. So he described the headache pain as gradual onset, frontal part, right-sided or unilateral, and throbbing in nature. So, however, he does not have any visual symptom, and he said that he takes paracetamol but of limited value, and his headache is preceded or accompanied by nausea and vomiting. So his mother had noticed some behavioral changes, which he becomes very pale and quiet, and he also will take himself to bed and sleep for several hours. After sleep, he seemed to be fine, and each episode of headache lasts up to 12 hours. And between the headache episodes, Tom seemed to be fit and well. And his mother said that he is happy at school and involved in numerous after-school activities, and he loved performing arts, especially dance. So, for his past medical history, he had a minor head injury at the age of 7 years old due to fall off from his bike. And however, there is no other significant past medical history, and he did not take regular medication for his headache, I guess. And for family history, his mother suffered with migraine as a teenager. So, based on this chief complaint, does anyone you guys would like to volunteer on what are the possible differential diagnoses that um, that match with his complaint? Can I call out Safura? Safura?
Yes.
Okay, so based on his symptoms, especially his headache pattern, gradual onset, frontal location, right-sided and throbbing, and also associated with nausea and vomiting, what do you think of the possible diagnosis for his condition?
I think he might be having migraine because migraine it is acute recurrent attack and it occurs at the frontal area or bitemporal and it can occur unilateral, and it can be associated with nausea, vomiting, pallor, photophobia.
Mm-hmm.
Then it is preceded by aura, like it does not mention aura here, and it can be due to genetic also, genetic, neurochemical, and also hormonal.
So, as you mentioned, he might suffer from migraine. What is the common duration for migraine episode?
Mm,
Do you know?
I think about 2 to 48 hours.
Okay, so it's also same as him. He had 12 hours of each
Uh,
headache episode. So what about the statement here? Between episode, he seemed to be fit and well. Does that correlate also to migraine?
yes, because that's the characteristic of migraine.
Okay.
The pattern of
Does
attack is separated by symptom-free interval.
okay? Does a migraine also have strong association with family history?
Yep, it is due to genetic, and when the parents salah seorang, what each one of the parent has migraine, it can be inherited to the child.
Okay. Does migraine headache have another neurological symptom or visual symptom?
Mm, for visual symptoms, it can be due to the aura.
Mm-hmm.
The child can have flashes, some kind of spots in his visual. Okay.
Okay, thank you. So thank you, Sapura. So basically, Sapura point out maybe one of the possible diagnosis is migraine. So as we know, migraine has two types: migraine with aura and migraine without aura. So basically, before we proceed with possible diagnosis, we should know the um, causes of headache based on the temporal pattern. So here are the classification of headache. There are four: acute, acute recurrent, chronic non-progressive, or chronic progressive. So we know that Tom had 2 years of headache, right? So it indicates that it's not an acute pattern of headache. So let us look at chronic non-progressive and chronic progressive. So chronic non-progressive, the headache is different from acute due to a greater frequency and persistent for years. However, there is no associated neurologic symptom or changes in headache severity. So this seems to be similar with what Tom portrays. So, and patient with chronic non-progressive headache may have emotional or behavioral components also. And the most common headache in this category is tension type of headache and also migraine types of headache. So, however, compared to chronic progressive type of headache seem to be like more to structural etiology causes. So, can someone appoint other differential diagnosis that may relate to his chief complaint, or anyone knows about tension type of headache? No.
Hello.
Okay. So,
Okay. Hello. Hello.
yes. So,
Before that, can I ask Safura regarding migraine?
okay, okay.
Yes.
Okay. So based on the case, what do you think the triggers that can lead to the migraine to Tom?
Mm, um, maybe we need to ask the mother more, because there are many triggers that can trigger migraine, such as stress, food allergies, chocolate, MSG. Then lack of sleep can also trigger migraine, and weather changes. So we need to ask the mother. Where in this case, there's no clue here.
Okay. So, it seems like we have to ask more about his food consumption or any allergy that he
Yep.
had?
Yep.
Okay. So another differential diagnosis from anyone? Hasif seemed to be interested.
I'm not saying differential diagnosis, but as you mentioned before regarding the tension headache, it is very less likely in this case because tension headache is bilateral and the pain characteristic, the headache characteristic in the tension headache is usually bracing or tightening, and also the what the tension headache, there is no any associated symptom. Normally, there is no associated symptom, but in Tom case, there is accompanied by nausea and vomiting, and also um, the headache in tension headache. It is not exacerbated by activities normally. So I think tension headache is very less likely in this case.
So are there associated symptoms that correlate with tension type? You don't know or no?
What do you mean?
Another symptom that a patient with tension type of headache will portray.
Oh, for tension headache is basically precipitated by significant stress, like emotional stress, poor sleep, or also disorder in eating, I think.
Okay, thank you. All right. So who would like to give another differential diagnosis that may relate with his past minor head injury at the age of 7 years due to fall off his bike? Does anyone would like to come up with other differential diagnoses that may relate to his past medical history?
Excuse me. I would like to suggest some space occupying lesion.
Uh, with occupying lesion.
For more accurately, the tumor, because tumor is a progressive, gradual progressive head apa ni condition, a chronic condition, and also if you look at the statement very pale and quiet, pale may suggest that this patient might having anemia. So anemia might indicate a chronic condition kan.
Mhm.
So I think we can consider lah trauma tumor in this patient.
Uh, would like to ask his mother more question that may bring you towards the tumor causes.
For example, family history. So what any other apa nama uh, altered altered behavior. So
Okay. Okay, thank you. Um, so what about his post-traumatic injury? Does anyone can come up with depression diagnosis that relate to his post-traumatic injury?
Zati,
Yes.
I want to add about the SOL, space occupying lesion, just
Okay.
now. So if there is a space occupying lesion, it usually associated with increase in intracranial pressure. So we can ask, is there an what makes the headache worsen? Because increase in ICP may be worsening by cough, micturition, and defecation.
Okay. All right. Thank you. So anyone would like to come up with the
Zati.
yes?
Zati, I think based on the statement about his past history of head injury, I would like to suggest intracranial hematoma because patient it could be from the unresolved bleeding or not fully treated head injury when he was at the age of 7. So it causes the wound to be still active and still bleeding. The active bleeding for a long time can cause a clotting that can cause hematoma. So what we can see from the case is that patient is suffering from headache which is chronic. So that is one of the symptoms for hematoma. Other than that, it could also be patient also has nausea and vomiting, which also highlights the presence of hematoma. And also patient, one important thing is that patient has a history of head injury. And also patient was very pale and quiet. Pale signifies also being mentioned by Wawa. Pale signifies bleeding. So it could be from the unresolved bleeding or the active bleeding itself. Otherwise, I would like to also ask further history in regards to any altered mental status or any neurological deficits or symptoms to further prove my diagnosis.
Okay, thank you. But may I ask, does
No.
hematoma or any intracranial bleeding causes lead to headache present acutely or in the long
It presents no, not acutely. Basically it normally the symptoms normally come like 2 or 3 weeks after, because it needs certain size of hematoma, certain size to elicit symptoms.
Okay. All right.
But
Thank you.
basically it's 2 or 3 weeks after bleeding.
All right. So basically we have ruled out certain division diagnosis. So the most likely we come out with migraine types of headache. Second is tension type of headache. Third is due to space occupying lesion. And also fourth is maybe due to hematoma, due to post-traumatic headache. So before that, I just like to share with you guys. These are the questions that that relatable if you want to know more about the headache episodes of that person. And not to forget, we shall ask about the lifestyle of the kid too. Does the kid has inadequate sleep or poor hydration, poor food choices, or caffeine intake? And family history, like Sapura have told us. And also, we can ask for social history for physical sexual abuse, bullying, depression, or family finances that may link to the headache causes of Tom. Okay. So I just like to give another differential diagnosis that causes headache. So basically, here I portray, okay, this is the primary causes and secondary causes of pediatric headache. So primary causes already been told by Sapura about migraine, tension type by Hasif, and cluster headache is another types of headache. But usually cluster headache is common among middle-aged men, if I'm not mistaken. And for the secondary causes, we can um, divide based on increase in intracranial pressure or infection such as meningitis, cerebrovascular disease like hemorrhage or vasculitis, trauma like this patient, he had post-traumatic headache, medications. So basically, certain medications may lead to headache, such as analgesic. Okay, analgesic that needed to treat headache may cause headache if longer usage of that analgesic. And another one is metabolic causes like endocrine disorder or toxic exposure such as alcohol, drugs, or inhalants. Epilepsy may also cause headache, rheumatological disease, and also dental disease. So don't forget to ask any dental problem among children, as dental can also cause headache. And this is the
Yeah, exactly. I think
yeah.
can you put the slideshow rather than
Okay, sorry.
I think Hasif is
All right,
struggling to
here you
see
go. Okay,
your point. So
can you
Hasif,
see it now?
is it
Has
better?
it okay now?
Hasif, better?
Better, better.
Better.
Alright.
Okay.
Okay,
Good.
Zati,
all
can I
right.
ask one more question?
I just want to make sure that all the welfare of the students are protected.
Okay.
Zati,
Yes, I am.
can I ask one question?
Mm-hmm.
Okay, regarding the secondary causes of headache, uh, can psychiatric disorder cause the headache in pediatric case?
Um, I think yes, because as I said before, one of the question that we shall ask is depression, because depression may one of the causes leads to headache. But detailed explanation about it, I'm not sure.
You're not sure?
Because
Because
no, because anxiety disorder can happen in pediatric, but I don't know about depression.
Oh, I don't know.
All right, okay, thank you.
so basically, as Hasif was mentioned about anxiety disorder can happen in pediatrics. So whether they really got a headache or whether it's a manifestation of the anxiety disorder, so they said they got headaches. Okay, so whether it's a true headaches, it could be, but at the same time, it could also be a manifestation of the anxiety disorder. They don't say to the parents or to the teachers that I got headaches, but it's probably because of their anxiety that basically end up as presented with headaches. So not necessarily they got headaches. It's just that they might have anxiety. Cuma they don't really know the words anxiety, so they normally just say I got headaches. Okay.
Okay. Thank you, doctor. Okay. So any other question before I proceed? Okay. So next, I just like to show the manifestation of migraine, since my provisional diagnosis for Tom is more to migraine headache, because as you guys have a look here, the manifestation of migraine headache based on patient age. So have a look at the 5 to 10 years of age. The patient might have bifrontal, bitemporal, or retroorbital headache, nausea, abdominal cramping, vomiting, photophobia, phonophobia, or a need to sleep. So basically, Tom has several manifestations such as nausea, vomiting, and also a need to sleep. So this might mm, be the positive points that migraine is the provisional diagnosis for this case. Okay. I think does anyone, other people would like to add on or have another differential diagnosis that causes headache in Tom case?
I would like to ask about migraine. Will migraine presented with a gradual onset? Is-
Gradual.
Because in Tom case, it's a gradual onset type of condition.
I've seen in a diagram that compare between migraine and also tension, and it seemed like migraine to be gradual onset. But I don't know if I'm wrong.
Does it mean that every episode the condition worsen?
Mm,
Would it be like that?
I'm not sure.
Macam mana? Worsen macam mana?
Macam every episode the condition worsen
For
migraine.
migraine. So
Yes.
For migraine.
the severity can be varies. So you might have just a mild migraine, but you can bear with the headaches for all day, and but sometimes you can also have very severe where you need to sleep, you need to take medication, try to get rid of the headaches, or try to bear with the headache. So the severity can be varies, but normally it comes slowly, and then it gradually getting worse and worse and worse, and then sometimes you got lacrimal secretion from your lacrimal ducts. You probably have vomiting and diarrhea, vomiting and nausea. So the severity is varies. So it can be very severe first time, but the second time it could be just very mild. It's slightly different to apa tu? Different to tension headaches. Tension headache tend to be quite severe onset, and it's always coming kind of abruptly. But coming abruptly, it's quite you got more severe headaches, mainly on the front and also on the back as well, and it also can cause vomiting and nausea, but it tend to be bilateral rather than unilateral. Sometimes tension headache can take a long time to resolve.
I have question.
Mhm.
Is it possible to include post-concussion syndrome as diagnosis? I mean, like in post-concussion syndrome, they will be presented with headache, and then sometimes it could be come with sleep problems and also some cognitive problems. So is it?
Mm.
But however, we know that the incidence of the trauma is actually already happened for the past 3 years. So is it possible to put post-concussion syndrome in diagnosis?
Mm, I think yes.
Oh, you think it's simple, very simple. Yeah. Any explanation?
Um, mm, tak tahu.
The history says it's a minor head injury. So it's unlikely for the minor head injury to cause long-term problems. Okay, so it's a minor head injury. I think most of the child will have minor head injury now and then. I think there's 20 of you, 20 of you probably have some minor head injury when when you are small. Otherwise you won't be able to do medical course now if you got a severe head injury, because severe head injury means that you might have fractures, you might have hematoma, you might have bleeding in your brain. So we call it traumatic brain injury if you got severe brain injury. So normally if you are involved in the road traffic accident ke, ataupun you fall from tingkat 21 ke, or tingkat 88 from the KLCC kan. So normally you have a severe traumatic brain injury that tend to have a long-term complication. Some of them develop into CP. Some of them might be able to might be able to walk, but their behaviors change. Their cognitive function also change as well. So I would say in this case, because it's only mild, head injury, I wouldn't say that the differential is due to post concussion syndrome, because post concussion syndrome does not last 3 years. Post concussion syndrome. So if you got head injury now, then your first presentation of nausea or headaches or vomiting normally happen within 48 hours. Okay, and then after that you will have these symptoms. They probably lasted for a few weeks, and after that things will get back to normal. And then normally mild head injury does not cause any long-term complication. It does not cause any cognitive problems. It does not cause any bleeding. It does not cause anything to do with the neurological sequelae. So that's why we put down as a minor head injury. Unless if you've got traumatic brain injury, bleeding, hemorrhage, and so on, then that would be a different story. So meaning that the complication will be much severe, and it will probably cause a long-term complication. So in this case, it's only mild head injury. Normally, it does not cause any long-term complication.
Okay, thank you, doctor.
Okay, so carry on, Izati.
Here I just like to share the other secondary causes such as sinus headache. So sinus headache is recurrent headache that approximately occur in 15% of children. So the nature of the headache is also throbbing. So it's similar with Tom. So we can, one of our differential might be sinus headache too. However, what differentiate from migraine headache? Sinus headache come up with a history of persistent upper respiratory tract infection, and you can ask his mother if does he had nasal discharge, congestion, or cough which lasting for more than 10 days. So if it's positive, it might due to sinus headache. So another causes is meningeal irritation. As I said before, one of the secondary causes is infection. So we can ask the symptoms of meningitis, and not to forget the alteration in consciousness. And as I said before, the medication obvious headache, as he had 2 years of headache, 2 years history of headache. So we can ask Tom's mother, does he had chronic use of medications to treat the headache, such as triptans or analgesic, as these medications can also lead to headache. However, his mother said he doesn't consume any medication right now. So these causes might be less likely for his diagnosis. So I think that's all. Does anyone like to ask any question?
Okay. Another question?
No.
No other question, eh?
Doctor, I have a question, sorry.
Mhm.
Can trigeminal neuralgia cause headache, or is this cause the facial pain only?
Mhm.
Can it leads to headache or apa ni, chronic headache, or it only involves around the face for trigeminal neuralgia?
Okay. Fine. So let's go back to your previous slide, Izati, yang ada apa? Yang ada primary secondary tu. Yang tu. Cuba besarkan.
Okay.
Besarkan.
Bentar lagi.
Tak nampak lah bongok. Okay, ada. Okay, ada. So trigeminal neuralgia. Some say it's an autoimmune condition. Some say it's a vasculitis condition. Some say it could be neurological condition that cause trigeminal neuralgia. The issue now is whether it will cause headaches. I would say it's yes and no. Yes, because of the pain around your left or right sided trigeminal area, and some people perceive them as headaches, and some people perceive them as a pain on the facial punya part. So sometimes it's difficult. It's up to you it's up to the clinician to diagnose whether this is a headache due to primary causes or secondary causes. To come to the trigeminal neuralgia, obviously you got a few more signs to do and to assess to come to the diagnosis of trigeminal neuralgia. In that particular case, I would say the headaches is a very subjective punya presentation. So some people say I got pain in the face, but some people say I might have headaches on the left side. So in that particular case, then people might say, oh, you might have unilateral sinusitis or or migraine because it's only one-sided, and so rarely you got trigeminal neuralgia bilaterally. So it's difficult to say because headache is something that patient tell you is a symptom, because headache is a symptom, and you as a doctor find the signs. So anyone can come to you with trigeminal neuralgia, but they will tell you they got headache. Okay.
Thank you, doctor.
Right. So it's very important to know from the history. You need to make sure what is the causes of headache. So primary causes and secondary causes. Migraine, tension headaches, and clusters headache. We go by the pattern of the headache. So the migraine, it tend to be unilateral, and with the symptoms, with the associated symptoms. Tension is like a band from the frontal to the occipital part. It's feel like somebody squeezing your head. Cluster tend to be cluster is so difficult sometimes because people might think it could be sinusitis that caused the cluster, and obviously the sinus is tend to be the sinus distribution. Cuma sometimes cluster can be just one place, and then people felt that it could people think it could be sinus that was inflamed that caused the cluster. So sometimes kita mungkin misdiagnose cluster headache as sinusitis. And then for the question is about try to get more details for the secondary causes of the headaches, especially the benign intracranial benign hypertension, benign intracranial hypertension, benign ICH. which was slightly difficult to diagnose as well. You diagnose them by imaging. You diagnose them by checking the pressures, opening pressure when you're doing a lumbar puncture. So those are the difficult one. And then sometimes vasculitis also can cause headaches as well. If you got systemic or CNS vasculitis, it come with chronic headaches, and normally they come with a daily headaches every day. Yang chronic, yang vasculitis ni. The other issue is sometimes you can have a low grade glioma, where you got a very slow expanding atau slow growing tumor in the brain end. So maybe at the time 1 year ago there's no sign, neurological signs, and then after a long time, because it's so persistent for about 3 to 4 years, and then the patient start to have nausea, vomiting, raised ICP, blurry of vision and so on. So those are the slow growing tumor, or we call it low grade glioma in the brain. So SOL is still possible in this particular problem. Obviously, if you're talking about astrocytoma, fossa tumor, normally they tend to be quite quick and quite short duration, and within a couple of weeks or within a couple of months. Metabolic conditions, it tend to be very early. Normally kalau metabolic condition ni, it tend to come with other symptom, maybe developmental milestone problem ke, delay ke, ataupun ada seizures and so on. So those are something to do with the metabolic condition, means that they will have other associated symptom or signs with them. Epilepsy, yes, sometimes epilepsy can cause that, especially kalau yang ada yang jenis ada aura kan. Epilepsy yang come with aura, so sometimes the patient can tell I got headaches, and then this headache will follow up with a seizure. So sometimes headaches can be a part of aura, and post-ictal states also can have drowsiness and headache as well. So it's all possible. But obviously you cannot say this is epilepsy kalau dia tak ada sign of seizure. Kalau dia tak ada, they have no GTC ke, absence ke, ataupun chronic seizures ke, atonic seizures. So you cannot say this is epilepsy because there is no pre-ictal, ictal, and so post-ictal. So to diagnose is a seizure, you need to have these 3 stages of fitting to diagnose this is a seizure. Any other question?
Let's say the patient is 2 years old and he or she can't talk yet. How do we ask the mother whether the patient had experienced headache, or how do we recognize the patient had headache?
So you cannot.
Cannot.
You cannot. So basically, normally, less than 5 years old, they don't really say they got headaches. Okay. Normally, at this particular age, where they are pre-verbal ataupun non-verbal yet, they just come with crying, irritable, orang kata miserable and so on. They don't really say they got headaches. Most of the time, what they will complain is, if, for example, if you got a 2, 3 years old or 4 years old, normally they say that they got pain in their stomach. That could be that they have headaches actually. So sometimes they refer headaches to they refer their tummy ache, but sebenarnya they are maybe they have headaches. So those are the things. So sometimes headaches in less than 5 years old is very difficult to diagnose. The thing is, macam solid tumor like posterior tumor, it tend to happen. The peak age is about 3 to 4, and for the posterior fossa tumor. So in that particular, normally you diagnose them very late, because normally they come with high BP or ataupun Cushing triads. They come with persistent nausea, vomiting. They might come with squeam, acute squeam, and so on. So to say to get the complaint of headaches from a less than 5 years old is so difficult, because they don't want to say they got headaches. But if you got a 3 years old or 4 years old say that I got headaches, and they point out their fingers to the head to say that I got headaches, take it very seriously, because normally most of the child less than 5 years old don't really say that I got headache. Okay, kalau diorang kata they got headaches and they point out to the brain, take it very seriously. You probably want to scan, do a CT scan urgently in that group of in that age group yang complain for headaches. Okay.
Okay, thank you, Doctor.
Doctor,
Mm-hmm.
can the headache, the nausea and vomiting be the early manifestation for pituitary tumor in children?
Pituitary tumor kan. Pituitary tumor normally tend to come with with a visual disturbance. Kan? So normally you got a bitemporal hemianopia kan, normally. So they rarely come. They can come with headaches. Cuma they come with headaches when the tumor is big enough to cause the raised ICP. So and then that's when the patient starts to complain of headaches. But before that, they start to have more symptoms of visual disturbance rather than headaches. Okay.
Okay, thank you.
So this is Tom, as Izati presents. So this is the examination findings. So he's otherwise healthy boy, well grown. His height and weight in the good centile. The heart rate is 68 beats per minute. The BP there normal. Otherwise, he looks normal, neurologically normal as well. Phonoscope is normal, peripheral is normal. So with these examination findings, you basically quite reassured that this boy has no neurological problems apart from the headaches. Okay, so from the history, very suggestive of migraine. Yang paling penting from the history is a recurrent, and normally between the episodes is always symptom free. Maknanya dia okay, dia sihat, dia between the intervals, and normally with migraine normally just one sided, and then the character dia throbbing pain, normally associated with nausea, vomiting, and obviously headaches in children is quite common. Especially for migraine. Kalau mak atau ayah dia ada family history of migraine, then this is probably likely to be the diagnosis lah. However, if there's no family history of migraine in the family, then you need to think about other diagnosis. For example, cluster ke ataupun sinusitis ke ataupun tension headaches. Okay, the classic migraine punya presentation dia ada aura. So kalau less than 5 in, normally they don't really know what is aura. Kalau probably about 10, 12 years old, they start to recognize what is aura. Okay, for those of you yang pernah ada migraine, so you know when migraine is coming because you feel the aura. So aura can be anything. Could be visual aura. It could be funny smell. But it's mainly the visual aura, the bright lights normally we call it. Obviously because with these headaches normally, with the migraine normally, children don't go to school because it's quite it's affecting their function daily. Obviously from the diet as well, you probably need to know the possible triggers. Some people yang ada migraine, they might be allergic to chocolate ke, cheese ke, too much caffeine. So those are they need to know what they eat that day that probably can trigger the migraine. Sometimes tiredness, sometimes stress also can cause can bring up migraine as well. Okay. As I say here, in young children, certainly preschool, an organic cause is highly likely. So if somebody less than 5 years old or in the preschool age, kalau dia kata dia ada headaches, then take it very seriously because it could be the space occupying lesion. Okay, so other differential of chronic headaches, think about tensions, sinusitis. It could be the eye problem as well. So one thing that I normally ask my MOs to refer is ophthalmology. So if somebody got chronic migraine or chronic headaches, I will normally ask my MOs to refer to the ophthalmology doctor just to check their power eye problem. They don't need to go to ophthalmology. So if they go to optometrist just to get their eye checked first, and then we can ask to go for ophthalmology if their vision is severely impaired. Obviously, you need to make sure that you check their heart rate and BP to look for the sign, to look for the cushion strides. Make sure they're not on any medication ataupun on regular medication. And obviously, headache is mainly about taking the thorough histories. Okay, if something that's suspicious, or if you don't think this is migraine or tension headaches, then always go for imaging. So either MRI or CT. If you think that this is possible acute migraine that have neurological sequelae, go for the urgent CT and MRI after that. Okay. So in terms of treatment of migraine, there's not much you can do apart from painkillers. If you think that there is triggers for migraine, then you can try to avoid the triggers. Some might consider giving macam sumatriptan ke ataupun beta blocker. Sometimes we can try gabapentin also, topiramate as well. I think in medical center we have pizotifen. We don't have sumatriptan to be given. Obviously, all of them have side effects, so you always mention to the parents that it normally use them as a PRM basis rather than a long-term basis. Okay, so take home message: young children, copy of headaches. Think very seriously, take it very seriously, and consider brain imaging low threshold for brain imaging, and obviously try with the lifestyle changes first before considering any medication to prevent migraine. Okay, any question about this?
Doctor, sorry to ask, what does it mean by lower threshold for scanning?
Low threshold means that if you suspect something could cause the headaches or the migraine, the headaches. Low threshold means that you do it. Maknanya meaning that macam high threshold high threshold, for example, let's say if you got somebody with pain, so somebody with pain, so you probably just say, oh, maybe dia boleh tahan pain tu. So you don't give anything. For those yang you think that the child won't be able to bear pain, then as soon as they say that they got pain, tapi if you look into the vital sign dia punya heart rate dia not going up, dia punya BP dia not going up, he does not look stressed, but you go for low threshold, maknanya as soon as dia complain of pain, you give medication. So that's what we mean. That you got low threshold means that if somebody complain of headaches, you go for CTs almost immediately. So those are low threshold, means that you doing CT on everybody who got headaches. Okay, faham tak? So low threshold. Tapi obviously we got the criteria for CT scanning. So if somebody less than 5 years old, have nose down, vomiting, other sign of cushion triad and so on, then there is all indication to do a brain imaging. Okay. All right. So, any more question about this case?
Doctor, why is it brain tumor? The headache is usually at late night or early morning that can cause nocturnal awakening.
Okay. So it's not late night actually. It tends to happen quite early in the morning. Okay. So one of the thing that you want to ask parents is, has the child waking up at night? So waking up at night, complain of headaches. Okay. The reason for that is because when you're sleeping, okay, so basically you are lying down. When you're lying down, your BP pressures, your heart does not need to pump harder to maintain your BP. Okay, so if you got SOL ataupun tumors in the brain, so basically the pressures in the brain is high. So when the pressures in the brain is high, then you will have reduced blood supply to the brain. Okay, how you going to maintain the blood supply in the brain is by your heart pumping much harder. So meaning that the heart need to improve or increase the systolic pressures so that it can maintain the blood supply in the brain. Okay, so that's why the patient yang ada brain tumor ni, they tend to complain of headaches when they are sleeping ataupun they've been lying down for a while, and then they're waking up at night, they're waking up with the headaches. Okay, and then why they got early morning sickening ataupun first thing in the morning they start to vomit. It's because that when this blood pressure is high in the brain, they cause more and more pressures in the brain. When they cause more and more pressures in the brain, so it kind of like induce kind of like mild cerebral edema that then lead to nausea and then vomiting. Once they're standing up after that, okay, when it's the edema is kind of reducing, at the same time the BP also reduces as well. Okay, so you got kind of reflex here, and then the BP then start to kick in. The heart need to pump much more harder, so you got a secondary high blood pressure because of the orthostatic pressure. Okay, so the child already has cushion triads, but with this orthostatic pressure movement, then you have a reflex hypertension because of that. Ada orang kacau Izzati ke? Okay, anything you want to ask? Okay, if not, then we can we can move on to the second case. Apa beza ni?
Saya.
Aina, okay, fine.
Sekejap, Nampak ke? Apa ni?
Okay, so just put in the okay.
Okay, so moving on to the case 2. So I'll just read it first. So Max is a 3-month-old boy seen in the community by his TP. He developed a runny nose and a bit of cough 2 days ago, but has become progressively more chesty and has now gone off. He spits and is having far fewer wet nappies. He has 2 older siblings who also have colds. He was born at 34 weeks gestation, but had no significant neonatal problems and went home at 2 weeks of age. So both parents smoked but not in the house, and his mother had asthma as a child. So first, let's move on to the complaint, which is runny nose and also a bit of cough, right? So and then in this complaint, it said that the cough has become progressively more chesty. So does anyone here know what does it mean by, or definition? How do you define this chesty cough? Anyone?
Cough yang macam kahak dia tak nak keluar, cari kahak. So,
Yes, that's true. So chesty cough is like a phlegm is produced to help clear your airways. Usually chesty cough means like it's a wet cough. So it means like there is a mucus, production of mucus. So do you guys know any other types of cough that you might know?
dry cough.
Dry cough, yes, that's right. So in dry cough, there's there's no mucus production. There's inflammation, but then there's no excess of mucus. For example, like GERD, for example, GERD that can cause cough, right? So there's inflammation, but then there's no mucus production. So ada any cough?
maternal cough.
Barking cough. Cuba.
Barking cough. So barking cough usually caused by?
Croup.
Yes, that's right, by croup.
Croup.
Okay, I think most of us already like pretty much know types of cough. So we can actually move on to the related cues. Okay, for example, next he has two older siblings who also have colds. So what do you guys think by this statement? The cause of the cough. Is it
Sick
infection
contact.
or not?
Stick contact.
Sick contact. So indicate that Max might have a cough due to secondary to sick contact to
His sibling.
siblings, isn't it? Yeah. So and then next, he was born at 34 weeks gestation. Jap. Wait. First, sorry. Before we move on to the that part, so what do you guys what come to your mind if the patient come with cough? So what the differential diagnosis that you will come up with? Plus the patient have sick contact. So what
Chronic
you
cough,
guys might do?
TB, tuberculosis.
Acute bronchiolitis.
Yes. Okay. Anyone?
Pneumonia.
Pneumonia. Okay, pneumonia. Okay, let's say that it was because of pneumonia. What other question that you might want to ask the parents?
Any fever.
Was there any fever?
Any fever? And any question that maybe we can ask the parents if the child look breathlessness or having shortness of breath, right? And then we can also ask if the runny nose or also the presence of the mucus, the color of the mucus itself, isn't it? Because it might help to know us to know is it the cause of the infection, such as usually for whitish sputum, different with the yellowish and greenish sputum, right?
Yeah.
Okay. So other than SOB, other than fever, what else what you might want to ask their parents?
So throat.
Okay. Okay. Let's say other hello. Okay. Uh, okay. So we just move on to the next sentence. So he was born at 34 weeks gestation. So may I know if any one of you know is it Max is born at preterm or full term or yeah. Anyone know?
Sorry.
In preterm.
The
He's a
preterm?
preterm.
Preterm. So full term at what gestation of gestation?
37 until 40.
7 to 39.
Okay. So uh Max is actually born at late preterm, isn't it? From what I've read, late preterm means birth between 34 weeks and 36 weeks of gestation. Okay, and then next few words said that had no significant neonatal problems. Why do you guys think that this come in as cues in this case? Does neonatal problems have are at risk to any other diseases, especially in respiratory system?
Maybe we can consider congenital infection.
Congenital infection. Okay.
And premature birth can predispose to recurrent respiratory infection.
Mm, okay. Mm-hmm. Okay. So next, both parents smoked but not in the house, and his mother had asthma as a child. So I think that we can actually put asthma in our differential diagnosis since the mother has a history of asthma, isn't it? But then what question that you might want to ask the parents if you suspect the patient had asthma?
Mm, any running history of asthma in the family?
Okay. Other than that, that's true.
Any previous presentation, like a same previous presentation?
Mm-hmm.
Um,
That's right.
so
So
you
Any
know there.
history of allergy or eczema?
yes, we can ask also history of atopy. That's true. Okay, and then we can also bear in mind there are many questions that we have to ask the parent related to the cough. So, for example, we if we come to our mind that the patient might have asthma, so we need to know when the cough is actually occur. Is it usually in asthma the cough will actually occur in the early morning, isn't it? There will be a pattern of it. Or if there's any triggering factors, for example, dust or the weather, so or any allergic reaction, so we can actually see the pattern of the cough, isn't it? Okay.
Yes.
So do you guys agree that we can if we actually can put asthma as our differential diagnosis in this case?
Yes.
Yeah.
Yes.
Yes.
Okay. So other than that, why do you guys think that the patient have problem with the feeding?
What?
Okay, in the statement, it
Uh,
said that the cough actually lead the cause the patient to have problem with his feeding and is having far fewer wet nappies. Why do you guys think this occur in patient? What caused the patient to have problems with his feedings?
The presence of sore throat maybe.
Okay. For what I know, so since the patient have progressively chesty cough, isn't it? So when the patient cough, so it will actually disturb the feeding process itself, the suckling itself. So that might explain the reason why the patient have far fewer wet nappies since there's a problem with his feedings. Okay, so I want to ask, do you guys agree if we actually put pneumonia as in our differential diagnosis?
Yeah.
Yes.
Presence of
Um, I would like to suggest because he has presentation of runny nose.
Mm-hmm.
So runny nose, we know that it is a symptoms of upper respiratory tract infection.
Mm-hmm.
So I think we can suggest a common cold
Common
because
cold.
common cold is very common kan,
Yeah.
especially in children less than 6 years old.
Mm-hmm.
So we can ask the parents if the patient has any ear pain. So and common cold also usually they will come with lack of appetite.
Mm. Okay.
Mm.
Okay, that's true. So, uh, okay, I want to ask, is it possible for us to put acute bronchiolitis as our differential diagnosis too in this case? What do you guys think?
Yes.
May I know why do you think we can put it as our differential diagnosis?
the age of the patient.
I'm sorry?
The age of the patient.
The age of Max?
Okay, usually acute bronchiolitis, the range of the age will be
Less than 2 years old.
usually 1 to 6 months lah, from what I've read. Okay, so but that's right. Any other diagnosis that might come out that you guys think in this case? No. Okay. Okay. So um,
I want to ask,
yeah.
does anyone come across to their reading with this? I mean, the exposure to food contact usually relate to upper respiratory tract infection or lower, or it can be both. Does anyone of you like
Sorry, I actually don't really heard what you are talking about.
okay, my question is, because as we know from the history, the child itself has attack to, from his sibling. So I like what
Sangkut-sangkut sangkut lah siapa ni?
Azhan.
Azahan.
I type
Oh, well, if the question is not 2 pages, I think you can type lah.
Azhan tak dengar.
Azan tak dengar.
Dia tak dengar.
Kalau tak silap dia tanya, kalau sick contact biasanya affect upper respiratory ke lower respiratory?
Oh, both.
Both.
Or both?
So, what is the consensus?
Hmm. I'm not sure.
Maybe it's depends on the organism
Hmm.
or is organism transmitted.
And also depends on the age.
Okay, semua agree kan? I don't know what point do you agree. I'm not so sure what point do you agree here. So if you mention about mana URTI, upper respiratory tract infection. So upper respiratory tract infection means that it's affecting the upper part of the respiratory tract. So from the trachea and above. So nose, throat, pharynx, and bit of above the trachea. And the lower respiratory tract means that you got from the lung parenchyma to the bronchiole, so to the alveolar, to the bronchiole, to the bronchus, and then to the big trachea. So those will be your differentiation between lower respiratory tract dengan your RTI. The thing is, any organisms can cause both. It can cause URTI, and then it probably started with URTI, and then because of these things stays there for a long time, so not normally it can goes down to the lower tract, so it become lower respiratory infection after that. Okay, so if you got somebody who are unwell and then you've been in close contact with them, and then it can cause either URTI or lower or LRTI. For example, the most common thing that we are talking about is COVID-19. Okay, the COVID-19, if somebody got it, and then if you've been close to them, then you can get the transmission through the droplets. Okay, so you probably started with a bit of runny nose, a bit of sore throat, a bit of high grade fever, and then and after a while, if you got a severe form of complication for the COVID-19, then you can have respiratory failure. Means that you can get viral pneumonia because of the COVID-19, and this viral pneumonia probably can progress into bacterial pneumonia for the secondary bacterial infection, and then you might have fluid in the lung or perfusion and so on. Okay, so whether it can affect it, or it can affect URTI or LRTI, it's all depend on your clinical findings. Okay. So somebody might have just URTI, and then if that somebody come close to you, and then you basically develop lower or pneumonia because of that particular person. So they probably carry the same bugs, but the presentation or the pathology that you will have is depending on your clinical signs. So if you do your if you auscultate the chest and there is capitation, there is reduced air entry, means that you got low respiratory infection, and even though other person already actually had your RTI je. Does it make sense? Okay, the only thing that I want to mention is if somebody says asthma, okay, and based on your Nelson's textbooks, what is the definition of asthma? What is the
Coronary
definition?
obstruction that is reversible.
So it's a reversible.
Has trigger.
Sekejap. So apa yang Nelson cakap? Yang saya kata is a reversible.
Reversible chronic airway inflammation.
Is it small airway? Is it big apa? Is it small airway or large airway?
Large airway. Small.
Semua tak ingat. Tak ingat dah asma. Asma is it large or is it small airway? It is reversible. It is chronic condition, but what part of the airways that it's affecting? Is it big or small? Okay, that's the question. The second question is, what age do you diagnose asthma? Regardless whether they got API positive family history positive ke, that you should have the cut-off point. Kan? Macam fever convulsion lah. You only diagnose fever convulsion if they have a fever and they have a fit, and then it happen between 6 months to 6 years kan. Somebody is very noisy Kau nak kurangkan noise Izati punya buat bising. Okay. So let me speak. So everybody need to be mute. Okay. Everybody hear me Semua orang here. Okay. So you need to have whatever cut off age. Kalau macam febrile convulsions, you don't diagnose febrile convulsion in the age of 2 months. It does not in the definition of febrile convulsion. Normally febrile convulsion is a fever that is associated with it's a fit that is associated with a fever between the age of 6 months to 6 years. Or some books says 3 months to 6 years. And if you got a fit with a fever at the age of 6 weeks ke ataupun 7 years ke 8 years ke, that's not febrile convulsion. It is something else that you need to look for. Okay, so same as asthma. So it's a reversible chronic. Siapa nak cari? Safura akan nak cari sama ada it's a large or small airway. So I'll leave it to you to decide whether it's a small or large airways. Okay, and normally the epidemiological definition, normally we diagnose asthma. Mana dia memang ada history of asthma, history of like a beta blocker treatment before, and it works. Normally we start to label a patient with asthma when they are about 2 years and above. Okay, the Australian punya guideline it says 3 years and above. So depending which one you want to use, but 3 months old we don't really put them as it does not really fit the definition of asthma. Okay, because of the age. Okay, it can present with other wheeze, other respiratory distress. Some of them might have crepitations. Some of them respond to beta bronchodilator and so on. But the age does not really fit the criteria to diagnose an asthma. Okay. So far, we're talking about bronchiolitis. So far, we're talking about possible pneumonia. Okay. Somebody asked about siapa cakap tadi? Oh, is a question that why the child reduce feeds. Siapa yang cakap ni? I remember. Who answered the question just now?
Apa dia doktor? Saya rasa saya jawab soalan tu.
So the question was reduced feeding kan?
Yes.
Why this baby has a reduced feeds? So is it because of the sore throat? Somebody cakap sore throat ataupun painful. Somebody says sore throat kan? Okay. So the question that I want to ask you, when does your lymph nodes, your adenoids, and also your tonsils develop? At what age? Anyone have any idea when is your tonsils start to develop? No idea. Okay, let's ask Najwa. So when actually your tonsils start to develop? In utero, 34 weeks, 36 weeks, 40 weeks, 1 month, 3 months, 5 months, 6 months, 2 years, 5 years? Eh? In utero? Sure tak sure? Adakah anda kunci jawapan itu?
I think in utero.
Utero, okay. Okay.
And
Everybody else
then,
agree? Everybody else agree with her?
I think at birth.
Hmm?
At birth.
At birth. So mana 39 weeks dia tak ada lagi tonsils. As soon as they are born, the tonsils start to come out. Boleh? At birth. Syuhada. So what age is your tonsils start to develop?
9 weeks.
9 weeks.
Not sure.
Okay. So I'm just going to put the answers on the chat box. Okay, fine. So basically your tonsils and your adenoids is not visible when you are born. Okay. And then it start to develop normally about 9 months, 12 months, and then it start to get bigger and bigger and bigger. And then about 4 or 5 years old, it start to shrink back. Okay. Okay, but sebenarnya the tonsils and the lymph nodes and the adenoids not shrink back. Basically the size is the same size, but because you are getting bigger, and then the size look relatively smaller when you getting bigger lah. So okay, so back to the question, why Max gone off feet with this illness? Adakah sebab dia sakit tekak, or is it something else that make him gone off feet?
Maybe because of nasal congestion.
Okay, so what happened in nasal congestion? What happened in nasal congestion?
I'm not sure, doctor.
Not sure. Okay. Okay, remember that babies, they are apa kita panggil, they are obligatory nasal breather. Okay, so maknanya baby ni dia memang akan bernafas ikut hidung dia, ikut nasal dia. Macam kita orang tua ni, me veterans, you guys are still teenagers. We can breathe through our mouth kan. So babies, because they need to breathe through their nose, if their nose is blocked with the nasal discharge and so on, and then their mouth is been fed with bottles ataupun breastfeeding, so they can't really breathe. So they cannot breathe through the mouth because they don't really know how to breathe through the mouth, and then they need to breathe through the nose. Cuma nose dia block, so that's why they cannot coordinate between breathing and feeding. So because they're blocked nose already, so they cannot breathe through the nose because it's blocked, and now they block their mouth as well with the bottle or with the breath. So that's why they have reduced ataupun gone off feet because of this blocked nose. Okay, faham tak? So that's why in these conditions, in this condition, they can't really breathe, they can't really feed very well because they got blocked nose. Okay, I just want to ask you one question. This is a developmental questions. Start from when? What age child learn how to breathe through their mouth? So what age they start to breathe through their nose? Sorry, I'm making a mistake here. I should ask. I should pick name. So I'm going to pick. Adawiyah. Sorry, Adawiyah is in the group or not?
Yes.
Yes. So at what age the child a child learn to breathe through the nose, through the mouth?
Maybe 1 years old.
What age?
1 years old.
Okay. Everybody agree 1 year old?
6 months and above.
Okay, somebody has 6 months and above. Okay, anybody else want to differ?
Three to 4 months.
I think when they start to win,
I choose 6 months above.
6 months above. Okay. This is very interesting. So most of you will say 6 months and above. So basically apa tu? They start to learn this the skill of breathing through the mouth about before the weaning. So normally about 4-5 months old. mana you start winning at 6 months old normally kan. So the child start to learn how to the skill of breathing through the mouth is about 4 to 5 months. Sometime from 3 months old they already be able to breathe through their mouth. Cuma they don't breathe voluntarily, yeah. So meaning that if you pinch their nose, and then they then automatically open their mouth try to breathe. So it's not a voluntary punya breathing. It's more that if you push them, if you pinch their nose, they will learn breathing through their mouth. Okay. Okay. Anything else?
No, not at the moment.
Not at the moment. Okay, so Aina finish ataupun still to carry on?
I already finished.
Yeah, finish ya. Already finish.
Oh yeah.
Okay, so somebody can summarize the case for me because I cannot missing what is actually the case about. Jadi apa? Case apa ni? So it's Max community chastity 34 weekers. No significant. Okay, fine. Okay, fine. So from the history, you guys suggesting it could be bronchiolitis, and so from the history itself. What point from the history that is putting the child at risk of developing bronchiolitis?
Max is 3 months old.
So the age itself?
Yes. So usually bronchiolitis occur in patient 1 to 6 months old. Yeah.
And also due to the seat contact.
Okay. And then what else? What else in this history?
Smoker parents.
So smoker parent. Okay. Anything else?
Chastity cough.
Because it's symptom, bukannya risk.
Preterm baby.
Preterm. Okay. So preterm baby on the highest risk of developing bronchiolitis. Okay. So mana if there is any siblings ke parents ke yang ada cold symptoms, it's very easily for them to transmit ataupun to transmit the small babies virus ataupun microorganisms, and then they tend to develop bronchiolitis very very quickly. Okay, so what is the definition of bronchiolitis that you know? So Nelson cakap apa definition of bronchiolitis? Asif, what is the definition of bronchiolitis?
It is the commonest lower tract infection.
Definition of bronchiolitis. Come on guys, definition of bronchiolitis.
Inflammation of bronchi.
So tadi
Inflammation of small airways.
So Safra kata asma semua airway ke large big airway?
Large airway.
I think it's large airway.
Large airway, okay, large airway. So bronchiolitis is a small airway. So inflammation of the small airways in the children less than 12 months old. Okay, some book says less than 2 years old, and it's a seasonal condition. It's a seasonal pathology. Okay, and normally bronchiolitis tend to be caused by viruses, especially RSV viruses. Okay, tapi ada je virus lain macam influenza pun also can cause bronchiolitis, and other adenovirus and so on can cause bronchiolitis as well. But the definition of bronchiolitis is inflammation of the bronchioles ataupun inflammation of the small airways. In the children, some book says less than 12 months old, some book says less than 2 years old. and it tend to be seasonal. Seasonal means that cold weather lah normally make the viruses more active. Okay, cuma in Malaysia we don't really have cold weather. We have musim tengkujuh. Okay, so we have the season, the monsoons. So the monsoons bring down the temperatures a bit, and that make the virus much more active, and it's very easily transmitted between children and also between people. Okay, so in adults, our bronchiole is quite big. So if you got RSV viruses in our throats and in our lung, we are not really affected with the viruses because our bronchiole is big. For babies, because their bronchiole is so small, so if they produce phlegm secretion, the bronchioles become blocked. So that's why they're struggling to breathe. That's why they have tachypnea, and sometimes with these blocked airways, they produce wheeze and bronchi, and also they produce capitation as well because of the movement of the phlegm. Okay.
Okay.
And obviously, you can put this as a pneumonia as well. I put in your chat box there is physical findings, but I think I'm going to share my slide so that you know what I'm looking for. So this is the physical examinations. The airway is clear apparently, but Max looks bit miserable. However, alert. The temperature is not that high. It's only 37.8, which is low-grade temperature. The other copious clear nasal secretions with a dry, wheezy cough. The spit rate is not too bad, 56, with the tracheal tuck, intercostal recession, and also subcostal recession and auscultation. The widespread fine crackles with the expiratory wheeze. Okay, and the remainder of the examination was unremarkable. So if you think this is bronchiolitis is basically clinical diagnosis, so you don't need any test to diagnose bronchiolitis. Okay, so you don't even need X-rays. You don't even need any blood tests. You just go for supportive treatment. Okay, as you mentioned before, most of you notice you guys agree with bronchiolitis. You guys agree with possible pneumonia. I don't agree with asthma. Apa lagi yang aku cakap tadi? So dua. Any other differential tadi?
Common cold.
Tuberculosis.
Okay, common cold. Okay, not too bad. I would say okay lah, but it's not really common cold lah. Because if you got Morinos, yeah, okay lah, you can put common cold lah, but physical finding does not really sound like common cold. Tuberculosis, 3 months old, only coughing for about a couple of days. So that's not really things that you would think about tuberculosis at this stage. The most commonest causative organisms in bronchiolitis is, I've already mentioned before, is
RSV.
and obviously there's other viruses as well. And what is normally the indication for hospital admissions?
Dehydration.
Less than 3 months old.
Okay, again.
We have signs of dehydration.
For feeding.
Toxic manifestation.
So this one, you in a different hospital use a different kind of indication. In PITS protocol, I'm not so sure the indication in PITS protocol. Probably ada juga kot. So basically, age less than 3 months, you kind of like admitted them. Poor feeding, you admit them. Respiratory distress, you admit them as well. Requiring oxygens. Ataupun poor very sleepy ataupun conscious levels is dropping, you admit them. Sometimes if they come to ED very late at night, probably about 11 o'clock at night, you admit them as well. If they live far from the hospital, you also admit them as well. So there's plenty of clinical factors and also social demographic factors that you decide for admissions. And what is the specific treatment for bronchiolitis in the hospital?
We can use saline solution.
Oxygen
Saline
therapy.
solution.
So oxygen therapy, saline solution, anything else?
So since the patient have a kind of poor feeding, we can give nasogastric feeding.
Okay. So what do we call this? What we call this management?
Supportive
Symptomatic.
management.
Okay, so it's a supportive management. Okay, so if the patient needs oxygen, you give oxygen. If the patient not feeding very well, then you can feed through the nasogastric tube. Okay. If the patient needs pressures, means that they need CPAP, you give CPAP. If the patient not improving by CPAP and that requiring intubation, you intubate the patient. So it's all about supportive treatment anyway. So there is no specific treatment for bronchiolitis. The nasal saline naps, the suction, treatment yang bagi nebulization ni, this is all about try to make the secretion much more runnier. So hopefully that the babies can cough up the phlegm, and the phlegm will move so that it's easier to be removed or to be discharged, so or to be sucked out sometime. And most of the time when the babies cough up, they just swallow the phlegm, and then it goes to the GI tract, and they normally end up with loose stool because of that of phlegmy macam stool yang ada lost the word now,
Lendir.
macam ada lendir kan kat stool tu. So those are the way babies get rid of phlegm, and sometimes they can just vomit their feet with the phlegm as well. So there's no specific treatment for bronchiolitis. It's all supportive treatments. Okay. The characteristic from the history and also clinical features for acute bronchiolitis, it tends to be seasonal viral illness. Normally occur, so this is all definition from textbook ni. So early autumn, spring principle affecting infants. So obviously in Malaysia kita tak ada autumn and spring, so we tend to say it's a monsoon season, so where temperature coming down. So kalau macam East Coast ni, it tend to be end of the year. West Coast is tend to be middle of the years. Those are the theoretical year. However, bronchiolitis can happen at any time throughout the year anyway. The commonest cause is RSVs. How do you test for RSVs? So there's orang kata ada kit to test for RSVs. You just take the nasal aspirate and then test for PCR or culture of the to detect RSVs. Most of our RSVs, if they are feeding very well, they don't need oxygen, they can manage at home. The thing is, if you are preterm baby, especially those who are very extreme preterm, they're requiring intubation for a long time, then normally we call it prophylaxis immunoglobulin injection. We call it palivizumab. This is just RSV immunoglobulin that you give to the ex-preterm, especially yang the chronic lung disease and oxygen dependent. However, this IVIG, this is IM injection. This is very very expensive as well. Rasa dekat Kuantan ni only HTA je yang buat injection ni. And then you give it every month throughout the seasons. Normally we'll give it from October until probably about January, February, depending on the monsoon seasons. Okay, so this is kind of an indication for hospital admission. So apneic episodes in children, in baby who has bronchiolitis. If the feeding is less than 50% of normal, kalau ada signs of low oxygen saturation, respiratory distress, ada sign of lung condition or congenital heart disease, kalau dia ada syndromic problems, macam transformer tentuan ke, ataupun ada heart condition ke, ada chest problem, extreme preterm, and also there's social factors that I mentioned before. Okay, the thing is, folliculitis tend to get worse between day 4 to day 7. Okay, initially, in the first 2-3 days, they are quite well, and then after, about day 4 to day 5, they produce a lot more secretion, so their airways become more blocked, become more full with the phlegm, and then they will struggle to breathe, and then they develop more severe respiratory distress. So normally you tend to you tell the parents that your child, kalau dia datang too early, maknanya the early stage they probably feeding okay, they probably not needing any oxygen, they probably breathing quite well. Cuma you mention and you warn the parents that they tend to get worse by day 4 to day 7. So they tend to, the graph dia macam okay je, and then they kind of dropping maknanya reduce feeding, become more tachypnic, and then the oxygen level probably lowering as well at the time. And then after day 7, they start to get better and better and better after that. So those are the punya kind of like rough timeline of the illness. And then obviously, as we mentioned before, management of mucolitis is a supportive management. You don't really need any investigation, not even NPA. Cuma ya kadang-kadang tu kita buat kita nak test for RSV ni sebab kita nak cohort the patient yang ada RSV. So maybe in terms of you want to isolate them. So if you got like 10 patient coming with mucolitis, you want to see which one is RSV positive. So if you test 10 of them, and then only about 4 of them yang positive, then you put the 4 in like in one cubicle. With the RSV positive mucolitis, and then the 6 of them probably you put somewhere else, just to make sure that the RSV does not really contaminate other patient. Sometimes with the mucolitis, you can have opportunistic bacterial infection or super infection. Basically a bacterial infection because of that. So if the patient develop high-grade fever, you probably start on antibiotics. Just to cover for bacterial infection. I mentioned about NG feed, I mentioned about oxygen, I mentioned about CPAP, intubation, and so on if required. We don't really give nebulizers or any bronchodilators because there's not really much evidence to support their effectiveness. Okay, however, recently there are a lot of trials doing budesonide nebulizers in bronchiolitis. I think the result is still not really recommended, but I think we need more trials and more evidence to start using budesonide in bronchiolitis. Okay, and then you discharge the baby when they're not requiring oxygen anymore, when they start to feeding by themselves, not needing any NG feed. Even though they have cough, even though they have wheeze, but if they are well, not needing oxygen, feeding by themselves, then they are ready to be discharged. Okay, the cough will persist for about a couple of weeks, probably up to 6 to 8 weeks. Sometimes the cough can persist up until 3 months. But those are the culprits, the complication of RSV. Some unlucky children, unlucky babies might develop bronchiolitis obliterans because of RSV. But those are the difficult one to diagnose anyway. You need further testing like CT, chest, and possible bronchoalveolar lavage to diagnose that. Okay, and then sometimes if you got recurrent bronchiolitis in the first years of life, we normally try with Montelukast, try to see whether it will works to reduce the recurrent bronchiolitis, but the evidence is not that really I would say not very well documented anyway. But we thought that leukotriene antagonist Montelukast can stabilize the muscle. Hopefully, the swelling of the bronchiole is not can be controlled with Montelukast. Okay, so my take-home message: Bronchiolitis is the clinical diagnosis. You don't need anything else to diagnose them. So far, all studies about treatment of bronchiolitis is all showing no benefits of treatment. It's all about supportive management, and we use palivizumab try to as a prophylaxis RSV bronchiolitis in the high risk groups. Okay, however, it's very expensive. Okay, any question?
Doctor, I have a question. I've read that the patient, in patient of pneumonia, the patient might come with symptoms of GIT like abdominal pain or diarrhea secondary to pneumonia because especially in lobar pneumonia, lower lobe pneumonia. Is it true?
Macam didn't get that. Macam mana ni? Apa pneumonia can have GI tract.
GIT symptom, especially if the pneumonia occur at lower lobe of the lung. So,
so I'm not so sure whether the location of the lobar pneumonia is significant or not. The thing is, if they got a lot of secretions, okay, because sometimes the secretion from the respiratory tract can go to the GI tract. So this secretion and so this organism can go to the GI tract and then cause inflammation around the epithelial lining of the gut. So that will promote more secretion being produced by the GI tract. So that's why most of the patient yang ada parenteral diarrhea due to pneumonia ni, because of the secretion from the GI tract and also secretion from the respiratory tract going to the GI tract. So those are the mechanism that it happen.
okay, thank you, doctor.
Okay, anything else? Any other question? Okay, everybody okay? Everybody happy? Okay, so so round the table, Najwa, okay? Okay. Any question, Shahada, okay? Ada question? Sapura, okay? Asif? Okay, Asif. Ada siapa tu?
Saya Amin. Nak tanya, what happened to the kid if let's say the kid undergo tonsillectomy at such a very young age? So what happened to the baby or the children growing up without tonsils? Will it affect their daily life?
Okay, so tonsillectomy ataupun removing your tonsils, normally we don't really remove the tonsils at a very early age lah. Cuma if there's any indication to remove early, for example, the child always have tonsillitis so many times, like 6 or 7 times per day. If the tonsil is a source of infection, mana if the tonsil can cause septicemia, then there will be a good indication to remove it at a very early age. Okay. The thing is, your tonsil is part of your lymph node system. It's part of the lymphatic system that act as your first line immune system, kan? Okay. The thing is, you only remove one part of the lymphatic system, so you still have so many lymph nodes that will protect yourself. Anyway, the reason that we remove the tonsils is because when the tonsil is big, the tonsil become the source of infection. Okay, so that's why children yang ada recurrent tonsillitis that make them have high grade fever. Some of them have septicemia. So there's no point to keep the tonsils because it then now become the source of infection. So when you remove the tonsil, you still have so many other lymph nodes that will protect you against infection. Okay, so meaning that let's say you remove the tonsil and then you have pharyngitis. So the thing is the organism that goes into your bloodstream through your pharynx is still going to be filtered through the lymph nodes anyway. So cuma lymph node maybe they use the cervical lymph node, they use the axillary lymph nodes. So not necessarily they use the tonsils as a process of filtering the microorganism. So you still have plenty of other lymph nodes that will act as your immune system lah. Okay.
Thank you, Doctor.
Okay. Fine. Okay. Hasil okay. Aina okay. Zaki okay.
Okay.
Amir Azan okay. Okay. Dewi okay. Okay. So if there's no other question, then we're going to adjourn our session with tasbih farad semua.
Thank you, Doctor.
Okay,
Thank you, Doctor.
Thank you for attending. Thank you for your participation. Okay, I'll see you whenever on the schedule.
All right.
Okay,
Thank you, Doctor.
Yes,
So,
Doctor.
Nah.
So sad.
It's recorded.
Okay.